Welcome back to Roadmap to Residency. In this video, we are tackling the acute surgical abdomen for Step 3, and we are doing it differently. We are not going to reteach appendicitis or gallbladder disease from the ground up. Instead, we are going to show you how the question writers build these vignettes and how to attack them so you pick the right answer even when the clinical details are fuzzy. We will cover appendicitis, cholecystitis and cholangitis, bowel obstruction and diverticulitis, with a special focus on knowing when a patient needs surgery versus medical management. To get the most out of this, pair the video with your question bank and a trusted review resource, because these patterns stick when you drill them across many practice questions. Let us dive in. Here is the plan. First, we will read the abdominal vignette the way a surgeon does, always asking who needs an operation and who can be watched. Then we will take our 4 heavy hitters, appendicitis, cholecystitis and cholangitis, bowel obstruction and diverticulitis, and learn the signature stem for each one so you can recognize it fast. The single most important skill is separating the stable patient who can be managed medically from the patient who needs the operating room right now, so we will keep coming back to that. Remember, this video teaches strategy. For the deep pathophysiology, lean on your question bank and your favorite review resource. Look under their general surgery and gastrointestinal chapters for the acute abdomen sections. Strategy 1 is about orienting yourself fast. Always read the last line of the vignette first. It tells you whether the question wants the next step, the best imaging test, or the definitive treatment, and that changes which details matter. Once you know what is being asked, use pain location as your first anchor. Right lower quadrant pain points you toward appendicitis. Right upper quadrant pain points you toward the gallbladder. Left lower quadrant pain in an older adult points toward diverticulitis. Diffuse pain with a distended belly and vomiting points toward bowel obstruction. If you lock onto location early, you can often eliminate 2 answer choices before you even reach the laboratory results. For a quick refresher on these localizing patterns, review the acute abdomen overview in your general surgery chapter. Strategy 2 is the heart of the whole topic. The exam constantly asks you to decide between medical management and the operating room, and 2 things settle that question. First, the vital signs. A patient who is febrile, tachycardic, and hypertensive is showing you sepsis, and that patient is moving toward urgent source control. A patient with normal vital signs who looks comfortable can often be managed medically or even as an outpatient. Second, the physical exam. Rigidity, guarding, and rebound tenderness are the language of peritonitis. When you read board-like rigidity, or pain with every bump in the road on the way to the hospital, or free air under the diaphragm on imaging, the answer is usually surgery, not more waiting. Keep these 2 filters in mind for every abdominal question. Your review resource covers peritoneal signs in its physical examination and acute abdomen sections. Strategy 3 sharpens the medical versus surgical decision. Start by memorizing which diagnoses even have a medical path. Uncomplicated diverticulitis and an early, uncomplicated small bowel obstruction can begin with bowel rest, fluids, and antibiotics. When you see the word uncomplicated, the writers are often nudging you toward that medical answer. Next, know the findings that force the operating room. Perforation, an abscess, an obstruction that will not resolve, uncontrolled infection, and a rigid peritoneal abdomen all push towards surgery or drainage. The moment a stem plants one of those complications, cross off the purely medical choices. Finally, let the cheapest useful test guide your imaging answers. Ultrasound is first for the gallbladder. Computed tomography of the abdomen and pelvis is the workhorse for diverticulitis, obstruction, and the undifferentiated belly. Avoid the answer that orders the most aggressive step when a simpler confirming test is right there. These imaging pathways are worth reviewing in the gastrointestinal and surgery chapters of your review resource. Let us work a classic appendicitis stem. A 22-year-old man has pain that started around the umbilicus and then migrated to the right lower quadrant, with nausea, loss of appetite, a mild fever, guarding, and an elevated white blood cell count. He is stable. The question asks for the most appropriate next step. Pause the video, commit to an answer, and then we will walk through why one choice is better than the rest. Here is the walkthrough. First, spot the pattern. Pain that starts around the belly button and migrates to the right lower quadrant, plus loss of appetite, nausea, guarding, and a high white blood cell count, is the signature appendicitis vignette. Second, confirm before you cut. because this adult is stable and the picture, while classic, is not a surgical emergency. This second, the standard next step is to confirm with computed tomography of the abdomen and pelvis. That makes choice A correct. Now eliminate the rest. Choice B discharges a patient who probably needs an operation, which is unsafe. Choice C orders a right upper quadrant ultrasound, which is the wrong region entirely. That is your gallbladder test. Choice D jumps straight to surgery and skips readily available imaging in a stable patient. Notice the theme: confirm with the appropriate test before the aggressive step when the patient is stable. For more appendicitis practice, work the right lower quadrant pain questions in your question bank. Now a gallbladder stem. A 48-year-old woman has hours of steady right upper quadrant pain after a fatty meal, with nausea, a low fever, and a positive inspiratory arrest when you press under the right ribs, which is the classic Murphy sign. She is not jaundiced, and she is stable. What is the best next step? Pause, choose your answer, and then we will reason through it together. As you decide, ask yourself what the cheapest useful test is for the gallbladder. Here is the reasoning. This is acute cholecystitis, inflammation of the gallbladder, given the steady right upper quadrant pain after a fatty meal and the positive Murphy sign. The cheapest useful test to confirm the gallbladder is ultrasound, so choice B is correct. Choice A, computed tomography, is not the first-line gallbladder test. Choice C, endoscopic retrograde cholangiopancreatography, is a bile duct procedure and is overkill for simple cholecystitis. Choice D rushes to open surgery without confirmation in a stable patient. Now here is the high-yield twist the writers love. If that same woman were jaundiced, spiking a high fever, and becoming hypertensive, you are no longer looking at the gallbladder alone. Fever, jaundice, and right upper quadrant pain together are the cholangitis triad, an infected, obstructed bile duct. That patient needs antibiotics and urgent drainage with endoscopic retrograde cholangiopancreatography. Train yourself to notice jaundice and instability, because that single detail flips the answer from ultrasound to urgent drainage. Review the biliary disease section in your gastrointestinal chapter to lock this in. Before we run the last two cases, a quick recap. For every abdominal vignette, ask 3 questions in order. First, where is the pain, because location shortlists the diagnosis. Second, is the patient stable, which the vital signs will tell you. Third, are there peritoneal signs or complications, because those decide whether the answer is medical or surgical. Now, a word on how the answer choices are constructed. The writers almost always give you one choice that is too aggressive, one that is too passive, one that fits the wrong region or the wrong organ, and one that is just right. Your job is to match the intensity of the answer to how stable the patient is and to what the imaging shows. Keep these filters loaded as we finish with bowel obstruction and diverticulitis. On to bowel obstruction. A 60-year-old woman has crampy pain, vomiting, and a distended belly, and she has not passed gas or stool for a day. She had abdominal surgery years ago, and her bowel sounds are high-pitched. Importantly, her abdomen is soft with no rigidity, and she is stable. What is the best next step? Pause and pick your answer. Keep in mind the filters we learned. Is she stable? And are there any peritoneal signs? Here is the reasoning. A prior abdominal operation is the classic setup because adhesions are the most common cause of a small bowel obstruction. The crampy pain, vomiting, distension, not passing gas or stool, and high-pitched bowel sounds are the signature stem. The correct next step is choice A, computed tomography of the abdomen and pelvis, which confirms the obstruction, shows the transition point, and screens for danger signs like compromised blood supply to the bowel. Now the eliminations. Choice B, immediate laparotomy, is too aggressive because this patient is stable with a soft, non-rigid belly, so an uncomplicated obstruction can begin with bowel rest, a nasogastric tube, and fluids. Choice C, colonoscopy, is the wrong test for a small bowel obstruction. Choice D, sending her home with a laxative, is unsafe and misses the diagnosis. The lesson is simple. A stable soft belly means confirm and start medical management, while rigidity, fever, or signs of compromised bowel would flip you toward the operating room. Drill obstruction stems in your question bank to see how the writers signal the surgical version. Here is the big one, and it ties the whole video together. Picture a 58-year-old man with 3 days of left lower quadrant pain, a low fever, a change in bowel habits, and a soft, tender belly with no rigidity. His computed tomography shows an inflamed sigmoid colon with no abscess and no perforation. That combination, stable patient, soft belly, no abscess, no perforation, is the definition of uncomplicated diverticulitis, so the correct management is antibiotics and close outpatient follow-up. Notice that colonoscopy during the acute attack is a classic trap because scoping an acutely inflamed colon risks perforation, so it is deferred for several weeks after recovery. Now watch the answer flip. If the scan had shown an abscess, the answer would move toward percutaneous drainage. If there were perforation, a rigid belly, ongoing sepsis, or repeated severe attacks, the answer would move toward surgery to remove the disease segment of colon. This single case captures the entire medical versus surgical lesson. Let the complications on imaging decide when the patient leaves the medical path. For the full staging, review the diverticulitis section in the gastrointestinal chapter of your review resource. Let us bring it home. For the acute surgical abdomen, anchor on pain location to shortlist the diagnosis, check the vital signs and peritoneal exam to judge stability, and hunt for the word uncomplicated, or its imaging equivalent of no abscess and no perforation, to find the medical path. When the stem plants perforation, an abscess, uncontrolled infection, or a rigid belly, move toward drainage or the operating room. The best way to cement all of this is repetition, so keep working your question bank and a trusted review resource side by side with these strategies. If this video helped you, please like the video and subscribe to the channel so you do not miss the next one. And when you are ready for a personalized plan, visit www.roadmap2residency.com to connect with our expert tutors and residency advisors. Good luck on your exam, and we will see you in the next video.